we have time to make it through these. So this is what I had originally planned to talk about. Basically, motor learning-based treatment approaches for upper extremity rehabilitation. So just to give you an overview of what I'm going to oops. Can I have these slides? Okay. So I'm going to start off by talking about, well, we already talked about actually motor learning in CP, but the idea that we don't know that much. And I'm going to talk to you a little bit about the motor learning approach to physical rehabilitation. The importance of intensity, as I showed you in these studies in motor learning, you need more intensity to learn new tasks or to improve in their motor performance than often we're providing. We're going to talk about models that we have used to achieve some of this intensity. And then what I'm particularly excited to talk about, and I hope I have enough time to go into detail, is the idea of looking at ingredients of physical rehabilitation, looking at what's the importance of actually performing skilled behaviors and progressing these behaviors, and where I think that we need to go from here. So when we think about motor learning-based approaches, these were developed by two physiotherapists from Australia who were students with my former colleague, Anne Gentile, where they began to apply what she had been talking about in physical education to rehabilitation of individuals with movement disorders, mostly stroke, but the same principles apply to children. And the idea being that you need to focus on basically motor learning, that with the recognition that what we think is control issues is that you're trying to teach children motor skills. So we need to understand, again, how you would go about inducing motor learning. And of course, it's recognition that therapists are increasingly aware that infants and children are active participants in their own treatments as opposed to passive recipients of this. So I'm going to kind of follow up with an additional statement from Anne Gentile in 1970. And what I want you to think about and what she's saying is sort of the seeds. This is 1970, but the seeds that are being planted for notions related to motor learning-based rehabilitation approaches.
One of the difficulties in American sports is that we coach for form, assuming we know. Mystery magic, assuming we know the form that works. We don't. All those things you read in the textbook are nonsense. Is there going to be one movement form that will work for these two fellows?
Probably not.
How about if he's tall or short?
No, he would have to make the adjustment where it goes into the adapting him to the movement.
So if he has to make the adjustment, why send him down the wrong road by giving him your adjustment?
Then you're going to teach 40 people on a football squad 40 different ways. I mean, you're going to teach each one individually is what you're saying, what you have to do.
No, I'm saying don't mislead them by telling them a form that you think will work. It may work for you. It will not work for them.
Then what are you supposed to teach?
You can establish the goal, set up the regulatory stimulus conditions, tell them...
Just go out and hit?
Wouldn't that be novel? And then...
So, kind of to summarize, she's saying that don't mislead the learner by telling them a form or movement pattern that you think will work. Ultimately, you want to set up a goal, establish the goal, and set up the environment, manipulate the environment to facilitate that goal, with the idea that these natural behaviors basically serve as directed towards accomplishment of goals, and they're aimed at specific purposes that we're trying to achieve. The idea being that the individual who has a particular constraints, a particular impairments, needs to ultimately problem solve a way of achieving that goal, giving what they know, or their brain basically knows, is their particular constraints. So, based upon the findings that I showed you earlier, that it takes intensity of training to induce motor learning, around 1997, we began to start to think about, well, how might we best induce motor learning in individuals with CP? And we looked through the literature in shaping and basically deafferentation. And around this time, some of the early studies of forced use and constraint-induced movement therapy had come out. CIMT had come out from Steve Wolf and Ed Taub, basically in adult strokes literature. And we wanted to adapt, and we did a case study published more than 10 years ago on a series of individuals with congenital hemiplegia. And since then, you can see that there have been a proliferation of studies of constraint-induced movement therapy, CIMT, more than 70 studies, and there's some review papers you can find that describe these in a lot of detail. Let me just show you a couple of findings that we have had over these years. One is that intensity matters. So this is this is the Jebsen-Taylor, that timed battery of tests that I showed you earlier. So faster time is better. You can see that individuals who receive 90 hours, 3 weeks, as compared to 2 weeks, generally improve more. So intensity matters. There seems to be a dosage effect, and we don't know what the optimal dose is. But keep that in mind with the idea that you've got many, many years to try to induce practice. This isn't, when someone comes along and says, there's only one way to do constraint-induced movement therapy, and if you do it any other way, you're going to lose the possibility of getting a slightly better, outcome. Well, even if that were true, and I'll tell you that there's very little evidence comparing different models, you wouldn't necessarily want to take away features that allow it to be child-friendly, basically making, having a comfortable restraint, not keeping it on 24 hours a day, embedding it into games and things that children want to do. You wouldn't want to get rid of those all at the expense of getting a 10% change in movement or improvements, if in fact you can just bring them back a year or two or whenever the therapist thinks is necessary. We have a lot of time to try to integrate these interventions. This isn't a miracle. It's something that just needs to sort of jumpstart the system so that you as therapists or who are sitting here can basically integrate that and move on to the next step. This is a study we did illustrating that point, where we took 8 children, it's a small group. We gave them a first pre-test. We gave them 60 hours of treatment, basically tested them on this Jebsen-Taylor test again. They show an improvement. We brought them back 12 months later. They've maintained what it is that they've improved. We gave them a second bout of 60 hours of constraint therapy, and they improve again, and they improve at about the same rate. So we don't know if you gave it again and again and again. We have some actually that we've done 3 times in any case, but we don't know how far can they get. But it's additive. So what you have to do is develop models that work for the children, work in the culture, the environment that works best for you, and not worry about getting the very most you can out of whatever short period of time that you have. So it's not a one-time miracle, and overall intensity, it's additive and it matters. I just want to point out that there has been one report from Volker Moll and Martin Stout's group in Germany, suggesting that the cortical spinal tract innervation pattern, meaning if they retain the normal contralateral projections or if they have a reorganization so that the ipsilateral tract controls the affected hand, may result in differential outcomes of constraint. So this is the contralateral innervation. You can see improvements. They use the Wolf motor test in a group of across a variety of ages. And you can see, in fact, that for the ipsilateral innervated individuals who participated in the study, and these are small numbers, actually there was a slight worsening of performance. So it's possible that to the extent to which kids will benefit may depend upon the particular neurological damage and the reorganization, therefore. Very, very small study. This absolutely needs to be replicated, but it makes you think a little bit about, the one treatment approach that fits all issue. It certainly drives some some interesting hypotheses. Okay. We as a group, met with a number of Europeans and a token Australian and a token American about a year ago in Stockholm. Basically this scene looks like something out of the Girl with the Dragon Tattoo. The idea was to discuss what do we know about constraint therapy and where do we need to go from here. And I'll just give you a couple of highlights, is that it works. Okay? It basically, across all models that have been presented, constraint therapy works. It works in young children as low as a year or 9 months. I would never do casting in that situation, but basically light constraint works. And it works in adolescents. It works in adults with stroke. It works when given 24/7. It works just 2 hours a day, at least in younger children. It works with casts, slings, gloves, and no restraint, as I'll show you in a bit, whatsoever. And repeated bouts work, as I showed you. So, it works in the Dead Sea, it works in the Red Sea. It doesn't matter. And I think what you need to appreciate is that all of these studies, including some of our earlier studies, compared constraint therapy to usual and customary care, given that usual and customary care schedules, frequency. So you have basically a difference in dosage of one thing. And all you can say is that a lot of one thing, constraint therapy, is better than little or nothing of something else, usual care. So there haven't been a lot of studies that have really looked at, well, what are the ingredients that matter? There is no evidence whatsoever that any specific model, and there are many, many models, is better than any other models. Because while everybody comes up with models in different countries that probably work in their local environments, and they never actually have been compared head to head. And even that comparison is a bit difficult because it might depend upon the particular environment, the country, the culture. It might depend upon the particular individuals. And when you do these small studies of 10, 20, 30 individuals, the extent to which that's going to generalize is limited. The sad part that we conclude is that, unfortunately, even though we made that initial burst in demonstrating efficacy, no new knowledge is being generated, as the same thing tends to be done over and over and over again. You develop a model, you test it, it works. Okay, so that is somewhat unfortunate. And in terms of, we came up with a bunch of suggestions, and I'll save that for the publication that will come out this spring. But basically, some ideas of things that need to be examined in the constraint therapy to move the field forward. I got discouraged after, we were the first to do these case studies of constraint therapy. And then, as I showed you very quickly, a lot of other people joined in. And I, unfortunately, came across many clinicians that were just casting children, doing usual and customary care, stretching, manipulation, normalizing the movement, working on range of motion, and guiding passively the movements. And I should point out that how many people here would say that constraint therapy is a motor learning-based approach? How many, raise your hand if you think it's a motor learning-based approach. How many people would say no? How many don't know? Okay, I don't know, because what everybody does is something different. And as I just said, some people are actually putting a restraint on and doing usual and customary approaches. And that might be a definition of constraint therapy in some cases, but it's not motor learning-based approaches. And then other people are, basically carefully applying and manipulating the environment and so forth. So it's hugely variable. You often can't tell from, in fact, you definitely can't tell from papers, because I've seen a great discrepancy between what people wrote that they did, and then I visit what their site is and see what's exactly going on. And it's hugely variable. And we got discouraged because therapists were thinking, it's the restraint that does it. This magic restraint. Cast them, send them home, and let that work. And they're missing the point that the restraint just provides an opportunity for practice. So we decided, what would happen if you just get rid of the restraint and you use the environment to generate elicit the movements that you're interested in. So we took bimanual functional training, something that OTs and PTs often do in the usual, practice, depending upon your particular theoretical approach. and we intensified it to the same intensity as constraint therapy. And we tried to provide the same ingredients as typically seen in constraint therapy to see whether we would elicit improvements. And so basically, habit, no restraint, same duration. These are all bimanual activities embedded into play and functional activities. And we progress the difficulty starting, basically using the arm as a paperweight, something very simple, and progressing it to a passive and then an active assist, and ultimately the difficulty would be progressed to actually manipulating, fine manipulation of objects. So we're grading the difficulty as the child has changes in performance. And we had a few studies basically looking at the efficacy. So our initial study, published a few years back, basically compared, just like I just said about comparing to usual and customary care. It's a difficult comparison to make conclusions. But this is the assisting hand assessment. It's a video-based analysis, blindly scored, of how the child chooses to use their affected hand as a bimanual assist. So basically the quality of movements and the choices that the child makes for bimanual hand use. So in this case, the higher the score, the better. And what we showed is that basically after 60 hours of training, you get an improvement in this assisting hand assessment as compared to the usual and customary care. But at 1 month, it begins to deteriorate. It tends to go back down to where it started. And basically, this is we put accelerometers onto the wrists that quantify the amount of movement that the child is using their affected hand. And this here is basically a typically developing a child, and this is a typically developing child here, and you can see that they use it 90-100% of the time. Here you can see that basically, if you look before, they typically only use it around 60% of the time, but after the treatment, and they maintain this for 1 month, they basically bring that up to about 80% of movement. So this isn't what you see typically developing children do, but ultimately you can elicit more spontaneous and consistent use of the affected hand. This is opposite, or different than quality, I should say, and they're uncorrelated, but nevertheless you can make changes in how often the child chooses to use the hand. Something important, I just showed you this curve here after 60 hours. If you up the dosage to 90 hours, you get approximately the same gain. This is a separate study, but it's maintained over the 6 months that we've followed these kids. So one of the things we did recognize in our constraint consensus is that dosage is something that's hugely important that we need to understand. But it's much more complicated than looking at dosage in pharmaceuticals, because it's not just the initial effect, it's the retention of that effect that you also have to consider. And you can see that in this case, you get the same initial effects, but there's retention if you provide 3 weeks or 90 hours as opposed to 2 weeks. Let's talk about specificity of practice. Thorndike had originally hypothesized that learning best occurs when practice is the same as the test construct. So we decided to look at or compare bimanual training, habit, to constraint-induced movement therapy, with the idea that there would be specificity of practice, that children who receive constraint would gain better dexterity, children who receive bimanual training would gain better bimanual coordination or hand function. So this is the Jepson-Taylor test of hand function, and it turns out that both groups improve statistically the same and retain that for 6 months. And I should point out, this is about a 30% decrease in their time to complete these items. One of the first slides I showed you is that over 13 years of development, you get improvements. Over 13 years, they were half the amount that you see here. So in 3 weeks, we can improve dexterity to a greater extent than basically 13 years of typical development with usual and customary care. So in a very, very short time, we can elicit large changes. We don't know what the ceiling or floor effect is, but basically these are large changes in dexterity. What it means is a separate issue, but we can improve dexterity. The assisting hand assessment, basically, we get significant improvements for both groups, and they're maintained over the 6 months that we follow them. So this is not specificity of training. As a separate issue, I showed you in one of the first slides in the previous talk the relationship between cortical spinal tract damage, basically passing through the peduncles, and dexterity, the Jepsen-Taylor. And you can see that that's true for our baseline scores, so it's highly predictive of their baseline hand function, but it's unpredictive of basically changes as a consequence of either of these interventions. So the hypothesis that I showed, that I just pointed out to you, wrong. It's not supported, not wrong, but it wasn't supported by our findings. But that's actually only partially true. As you know, as people working with children, goals that are important to caregivers and to the children are especially important in rehabilitation. And when you do the Canadian Occupational Performance Measure and you basically look at goals, basically you get larger changes in goal performance as perceived by caregivers for the bimanual training habit group as compared to constraint therapy, both in terms of performance and satisfaction. And I should point out a little bit of an unfair comparison, because the majority of goals that parents have are self-care and play activities related that involve both hands. The bimanual group gets to practice that up to half an hour a day. The constraint group, you can't do that, basically, at least in this situation, and they can only work on subcomponents. So if they're doing zippering, the therapist has to hold the jacket while they pull the zipper. So they're not actually working on the same things. But specificity of practice does seem to hold true here. We also, the drawer tasks that I showed you, they start off in terms of the overlap of movement around 25%, and you get improvements in the amount of overlap of the two hands for both groups, basically around 65%. A typical adult or child would be about 80%. So they had a great improvement in the bimanual training, but not as much in the constraint group. So when you look at more detailed biomechanical analysis, you begin to see changes in coordination in bimanual training that they didn't get as much in the constraint therapy. And this is not a task that they practice during the training. So there is a generalization of using the two hands to ultimately to the performance of this particular task. Conversely, we did a unimanual grasping task, and we looked at how much does the shoulder contribute to the reach? Basically, are they independently extending the elbow and shoulder, or are they basically moving the trunk? And you can see that the constraint group basically had a reduction in the trunk contribution to the movement, more independent arm movement, but no changes in the bimanual training group. So there is specificity of practice here. I'm actually going to jump ahead. So one question that should obviously pop into your head is, I've been talking about a comparison of one to the other. But the reality is, in the therapeutic, and we're doing this in a, ivory tower, very carefully controlled studies, but in the real world, you have a choice of which one to use or combining the two. And in Israel here, there was a very nice study published last year by Marilyn Cohen at Evelyn. And basically, she did 1 hour of constraint followed by 5 hours of habit for 2 weeks. And these are the AHA score, the assisting hand assessment, and you can see that following the intervention, they have large changes that are maintained over 6 months. So the combined approach definitely is something to consider. And basically, that's similar to what Pauline Arts had done in the Netherlands, where she did 6 weeks of constraint followed by 2 weeks of bimanual. I'm going to jump ahead. Here in Israel, Dido Green and Mitch Schertz and a number of other individuals did some magic habit camps. So basically bimanual training using the learning of magic as a theme, and they compared basically the findings of a camp here in Israel with 2 camps that were conducted in England. And basically you can see that for all camps you get changes in the assisting hand assessment and decreases in the Jepson-Taylor test. So this magic theme approach seems to work. Again, these studies, these are not comparison studies of one approach to another approach, and ultimately that's where we really need to get to. And I'm not going to talk about it, but there are a number of individuals here that have been doing imaging studies, and I think some of that's going to be presented over the course of the next 2 days in terms of prediction of hand function, but also prediction of changes using, in these camp-type models. And I think the results are definitely really interesting and are going to provide some nice hypotheses. So to summarize so far, constraint therapy and bimanual training improve both unimanual and bimanual function in a similar way. And we're not the only ones who have shown that. There are increasing reports that are pretty much showing the same thing. Bimanual training may improve the coordination of the two hands to a greater extent and allow the function of meaningful goals, but unimanual training may improve unimanual control. You have much more control over the affected hand when you constrain the other hand, and if you want to work at the impairment level, that's a much easier way to do that, because you can control it very, very easily. But again, these are not mutually exclusive approaches, and they can be combined either in one camp approach or one intensive bout, or in succession over multiple points as seen fit by the therapists. So I'm an upper extremity chauvinist. Basically, most of my research is on upper extremity, but the question arises is can you use these approaches to train the lower extremity, at least in these individuals here? And we've been collaborating with Yannick Playenhoft in Brussels, where she had a sleepover camp in a park setting, and basically children sat on these fitness balls, but for about 6 hours a day did fine manipulation, and we basically drove postural control by making the balls more difficult, or ultimately having them kneel for periods of time or stand on a balance board, and kind of combine upper and lower extremity training. But also in the afternoons, we did a lot of gross motor activities that really required the use of trunk, and we would do relays and other things involving walking and running and so forth. So basically 12 children aged 6 to 13 and 90 hours of training. So we're calling this Habitile for now. We don't really have an acronym, but we need to in the next month or two when we submit the paper. But basically, you can see that from the pre-test to the post-test, you get changes in the assisting hand, the able hand kids here that are about the same as that in other habit or bimanual training approaches. But this is the AHA here, and you can see it also like similar changes that occur to what we've been talking about. But you also see changes here in the 6-minute walk test. You get an improvement in their movement speed, and the same is true if you look at the time to get up and go, the tug, the 10-meter walk test, and basically even the gross motor function. You see some changes in that as well. I should point out another study that looked at lower extremity or whole body control here from Israel, a nice study looking at motor learning coaching, which very carefully defined principles of motor learning as we know in adults, typically developing adults, and applied that and compared it to individuals with NDT. So basically these are level 2 and 3 gross motor classification, basically looking at the effectiveness of motor learning coaching on retention and transfer across activities. 78 children with spastic CP, basically gross motor function, as I said, 2 and 3. And it was 1 hour a day, 3 days a week for 3 months of treatment. So it's quite a bit of treatment. And actually, quite beautiful results, actually, that what you can see here is that you can, in the GMFM 66, measuring their gross motor function, for both groups you get improvements from pre to post that are maintained over 3 months. But you bring them back 9 months later, the group as defined as NDT begins to decline a little bit, or statistically, as compared to the motor learning coaching. So I think there's a lot of promise, both in terms of thinking about motor learning and the application to rehab approaches, but also thinking about intensity. And this wasn't terribly intensive. The question would be, what would happen if you increase the intensity of training this even further? But the findings actually are quite good for that period of time. An obvious question: these camp models are ideal in the ivory tower, basically in well-controlled situations. But they're expensive. Who's paying for these? They're hugely time intensive for families to be able to devote to, and for basically for us to be able to do. So the question is, does it matter? And Nava Galkop did a nice study, which is going to be submitted shortly, comparing constraint and bimanual training in a preschool environment, and basically following them for 2 months of usual and customary care at the same frequency, and then 2 hours a day, basically giving them either constraint therapy or bimanual training, and then following them up for another 2 months where they receive basically the usual customary training again at the same schedule. And the AHA is stable statistically here and here, but you get large improvements in these individuals, basically, which are similar between the two treatment approaches as I've showed you. So there is no specificity of training. Both approaches can be implemented intensively in school environments. And they raise the issue about rethinking about these usual and customary care schedules. These, it may be better to basically provide the training and intensive bouts here over short times. And that's something that I think that needs to be tested and considered. All the results that I told you earlier, we had our interventionists are either PTs, physical therapists, or occupational therapists, or they're undergraduate and graduate students that are supervised by PTs or OTs, and they're trained in consistent manners. And the findings are similar for basically regardless of whether the child had a PT, OT, or just somebody that we were supervising. So I don't think that this necessarily requires the expense of having one-to-one PT or OT per child. This is a study done in Jordan where therapists went into the home environment, as opposed to the preschool or camp environment that we've been doing, and basically showed that compared to NDT, that they get large changes in constraint therapy, basically over a 2-hour-a-day model in the home environment. And we've also done a home training looking at bimanual training recently, where we provide 9 hours of trainings to caregivers, and they give a total of 90 hours of training. We give them a midway sort of refresher, and once a week we go to their home and we basically watch them. It's 2 hours per day for 9 weeks, and then we follow them for 6 months. And we have a number of kids that have gone through. This is assisting hand assessment, and lo and behold, we get changes, on that small number of kids that we've tested so far. And we've been looking at feasibility of the various approaches and how do caregivers think about, and how are they able to integrate this into the schedules and so forth. It's a complicated approach to do this, but it is possible to train caregivers to basically provide adjunctive treatment. So to summarize up to now, there are benefits of intensive motor learning-based approaches, and they're not limited to just the upper extremities at this point. And this is, I think, a promising area of research and rehabilitation that needs to be looked at further. These can be administered in camp, schools, at home by therapists or trained students, or even caregivers. The last topic I want to talk to you about is ingredients, basically motor skill learning. So we know that from the animal research on plasticity, that newly learned movements are represented in larger cortical areas than basically existing movements. And we know that repetitive movements alone don't induce changes in cortical representations in rats and monkeys as compared to movements involving the acquisition of a new skill. So basically, it seems that, at least in these animal models, motor learning is a prerequisite for plasticity. This is, I'll very quickly go through this, but a study by my colleague Kathleen Friel, who originally trained with Randy Nudo and Jack Martin at Columbia, and now myself adopting this to humans. They've developed a cat model of forced use and effectively constraint therapy. So they had cats in which they basically induced a hemiplegia by the injection of a GABA agonist, Musomol, into the motor cortex, basically at different points, and then restrain the contralateral constrain the unaffected extremity, and either left them 23 hours a day with a restraint on, and they passively could walk and eat and so forth with that hand, or they provided 1 hour of training where the cat would have to reach towards pellets and do some of those behaviors that I talked about when we did the individuation training, basically requiring progressively increasingly skilled behaviors. And this was done from either 8 weeks to 13 weeks postnatally, basically following a period of this inactivation of the motor cortex. I'm not going to go into detail, but they had another group where they did the same thing in adolescents and compare, well, when's the appropriate age to give this as well. Okay, so one of the skill tests that they have is they have cats walk across a ladder. And what happens is after they have the inactivation of the motor cortex, they often have a forward overstep. They basically fall into the crack by overstepping the rungs of the ladder by about 2.5 centimeters on average. You give them early training, week 8 to 13 postnatally, with actual constraint, and basically there's a constraint in the training, and they improve basically down about 1 centimeter. They increase their accuracy. When you do the restraint alone, without the skill training, there are no changes. Basically, this group basically continues to have large missteps towards these rungs of the ladder. So it seems that skill training, or you can almost think of this as being constraint therapy and this being more of a passive forced use, the skill training seems to be important for driving motor function. But that's also true, and I won't show you the slides of the motor representation, but this is the connectivity and the use of choline acetyl transferase, basically neurotransmitter, and its neuroenzymes in the spinal cord, and the representation of the connectivity basically at the spinal level here. So in the cat model, basically rehabilitation actually decreases. Without rehabilitation, these inactivity of the motor cortex, you result in a decrease of the cholinergic function in the spinal cord, inducing action potentials. And this is by Jack Martin and colleagues. But when you have early training of the basically early training, you can actually maintain that the asset, basically the chat here. And the restraint alone, that's also true, but not quite to the same extent as with early training. So you can see some differences in the actual neurophysiology of the projections of the and the use of cholinergic function in the spinal cord here. Okay, so we decided to ask the question: does structured skill practice matter in children manipulating the ingredients? So we did a small randomized trial of 24 children, age 6 and above, and we had a structured practice group. Structured practice being defined as I've been talking about with constraint therapy and habit, meaning that we use the environment, we progress the skills, we do part practice, we work on goals, so there's motor learning and so forth involved. We also had another group which was unstructured practice. So this is a group of individuals who are separately trained by therapists, basically, or trained interventionists who are unaware that there even exists another group. And they're just engaged their children in play. The only rule is use your hand for all the activities, but we even go out of our way, we monitor carefully to make sure they're not, doing anything to overly motivate their kids, to progress the skill. And we tell them, no, don't do anything that makes the task more difficult, even if you think that they can, because they receive therapy during the year, and this is a summer camp. We don't want to stress the children out or make them frustrated. So literally, it's just repetition, as they had done in the animal models. Day camp environment. We don't have the AHA scores back, or all of them yet, but the Jepson, Taylor, Abraham Kids, and GOLD performance monitoring, Canadian Occupational Performance Test. And then basically we follow them for up to 6 months. So the evaluator and the interventionist are blinded to the hypothesis. So the hypothesis being that individuals in the structured skill practice will have greater improvements than participants in the unstructured skill practice group. Well, this is a control group who received usual and customary cares. This is pre-post, and no significant changes. This is basically, you can see in the Jepson-Taylor test, you get significant improvements in both the structured and unstructured practice group. So these are not significantly different in terms of the difference in improvement. They're both significant from pre-post, but the amount of improvement is in fact the same. This is the Able Hand Kids, just a kind of a questionnaire of hand function and use by the parents. And same thing, both groups show significant changes that are maintained, but no difference in the slopes of these changes. So in terms of our hypothesis, wrong again. It's actually kind of fun to be wrong, because it really kind of drives our questions and thinking. But if you're taking notes there, be careful, that I'm not sure you would believe everything that I'm saying. But as you'll see, we actually looked at the changes in the motor cortical representation using transcranial magnetic stimulation. Basically, we use single pulse TMS, and we map in a predefined grid around the hotspot of activation. We co-register it with MRIs. We record motor evoked potentials in the FDI and wrist and biceps. And basically, we map this bilateral basically around the hotspot. Using 110% of the pretaining motor threshold used to evoke the MEPs, the motor evoked potentials. So the same intensity is used before and after training. So first off, using this technique, we can actually differentiate children who have contralateral projections of the cortical spinal tract, or purely ipsilateral innervation, or a mix. The mix is a little bit more tricky. And these are relatively small numbers at the moment. We're still analyzing more data and collecting more data, but what you can see is that in this bimanual training, this is the ipsilateral training group, and you do get significant improvements in their Jepson-Taylor test that's maintained. This is different than what Stout had reported for constraint therapy in these same group of individuals. So we don't know, we're not saying that he's wrong, but we are saying that bimanual training does induce changes in unimanual function, even for these children who have basically ipsilateral non-cross cortical spinal tract. Now, these are the representations with the MEP values, thresholds kind of superimposed by color here around the motor cortex. And this is of a child who has basically a contralateral projection before and after training. And you can see a large expansion of the motor map affecting the, basically innervating the digit, FDI, after training. You also can see in individuals who have ipsilateral innervation, the pattern doesn't change. Even after training, you can't induce MEP by stimulating the contralateral cortex. So the overall pattern stays the same after training. But again, you can see a large expansion of the motor map that occurs as a consequence of the training that they were underwent. So there's a catch. And the catch to this is the structured skill group. And on average, you get more than a 50% increase or expansion of the motor map of these individuals after training. This is the unstructured practice group, and you get, on average, almost nothing. I think it's pretty interesting that there's a dichotomy, that you get a change in skill, a change in motor performance, but what we typically think of as plasticity, measures of motor maps or hand size representations, size of hand representations in the motor cortex, it doesn't change. Now, that doesn't mean neuroplasticity didn't occur. It just doesn't occur in the way that we typically think of and measure plasticity in the cortex. For sure, every behavioral change has a neural correlate, but it's not measured as we are doing here. And there is one difference. I lied about the hypothesis. The kids who, again, practice their goals in the skill training group improve more on the goals than those that don't. So I suspect that this motor learning, the learning of new activities and the challenging the environment and the structuring the activities is what drives the group, basically, that you see changes in the structured skill practice group. So motor learning is the key. So to summarize, at least at these very high dosages, structured skill progression may not matter. I would still personally do it, and basically because we're seeing changes in plasticity, we tend to see more motivated therapists when they're challenging their kids, and I think it's probably a more fun environment if done correctly. If I only had 30 hours to give a camp, I would bet that there could be a difference, and I wouldn't take the risk of eliminating this. Skill training is optimal for improvement in functional goals and definitely in motor cortical plasticity. There might be a dichotomy between what we think of as plasticity using TMS and behavior, and it raises the question of what does motor cortical plasticity mean? And that's something that for years we've been studying in adults, and no one's ever sat back and it's like is it functional what we're saying? So to conclude the talk, the old adage of how do you get to Carnegie Hall? Someone asked, a tourist asked in New York, and it's practice, basically. And it's basically, if you want to play the violin, you practice the violin. You practice specificity to some extent. Intensity absolutely matters. There's no question that everything that we've been doing is, intensive, and that kind of rules out a lot of other things. Maybe you don't have to be as bright in what you're doing, if you do enough of it, and that's something to really think about. But intensity, it's necessary, but it isn't sufficient. And this is something that Mitch had proposed in a review that he wrote a few years back in my lab about treatment across a variety of different disorders. Who, what, and where we do these interventions, maybe that doesn't matter. It's important to remember that we're working with individuals, and there's huge variations in what works for them in terms of what are their pathologies, what are their outcomes, what are their personalities, and what's the environments that can best drive them. So it doesn't, in the end, really matter what someone tells you in a study. You still ultimately have to figure out how to best apply that to the individuals that you're working with. I would say that what I've shown you is that if you use, in many cases, just standard clinical outcome measures, even if they're validated and shown to be sensitive, you may not see differences in groups or ages or comparisons, but if you follow it up with neurophysiological measures, it doesn't have to be TMS, it could be biomechanics or just careful analysis of the coordination, even using a video camera, you may suddenly see differences that wouldn't emerge in these time tests or other types of rating scales and so forth. And I think that the key ultimately may be goal-oriented training involving motor learning. So coming back to what I showed you in the very first slide of the previous talk, where we have kind of a interplay between development and the neural mechanisms underlying movement disorders and systems neuroscience of typically developing children and adults. And I think for us to understand motor learning approaches, we need to understand motor learning. We don't know enough about how children learn. And I think that we need to do basic studies, simple, in the clinical environment, using functional tasks, understand how do children learn. So we don't have, the right ingredients, or what I would say, we have high dosages right now. And to be honest, without that, I think we're doing great. The last 10 years, we've seen great progress in rehabilitation, especially of upper extremity, but including lower and many other areas. But I think we can do much better, and to do that, I think we need to rely more on new information that's coming about mechanisms, about normal motor control. So I'm not satisfied where we are, and I don't think that you should be either. So, thank you.
אני קודם כל רוצה באמת מחיית כפיים מאנדי שבאמת הגיע בשבוע הזה ובא במיוחד, וזה לא מובן בימים אלו שמישהו מחוץ לארץ מגיע וככה נמצא איתנו, אז באמת כל כבוד. And they give you a big יישר כוח for coming this week, despite everything. Obviously many of the things we're hearing today are very, very important to have a significant ramifications for the work we do on a daily basis. I'm going to need to cut things short, very short, because of the issues of time. I'm going to allow 2 questions, and then we're going to break, and we're going to defer the meeting of the אספה כללית לאחרי ההפסקה. אז קודם 2 שאלות.
יש לי שאלה. I'm a pediatrician in a well baby clinic from 0 to 5. First of all, I would like to ask, what about the hemiplegic in a very early stage, immediately after their discharge from the hospital? You mentioned the amount of practice, but timing, I think, is maybe as important as when you deal with an infant. Because the plasticity is in the first 3 months the major, so why not to start a very intense treatment from the very first day when they are discharged, and maybe later, maybe train the mother to start until she will have an appointment with the physiotherapist, because it takes some time, 2 or 3 months until when they start. The second question is when I'm...
Can I answer that one first? Is okay? I have a hard time putting these 2 together. So, first, that's a great question. Janet Eyre in Newcastle has been studying the typical development of corticospinal tract and development of that in babies who ultimately develop hemiplegia. And basically, what she shows is that during the first 3 to 6 months of life, they have sort of the same developmental pattern of the corticospinal tract, meaning that you have a bilateral innervation in which basically they're bilateral, and what happens is typically developing children strengthen their contralateral projections and withdraw the terminations of the ipsilateral projections. And then the children with hemiplegia do the converse. They strengthen their ipsilateral tract and to some extent or completely withdraw the contralateral. So the problem from a neurophysiological standpoint, you actually, and what it seems to be is in the CAP models of Jack Martin suggests is that that's activity dependent of movement. So typically, and there's a huge variations in controversy, but typically the first signs of hemiplegia happen around that time, around 3 to 6 months of age. And at that point, actually, you've already had a change in your neurophysiology, and then they stop moving the upper extremity, and that further drives the change in the neurophysiology. So ultimately, it means to really, really address it's probably at 0 to 3 months with children at risk, and you need to know who those children are, and you don't always know that. But there's no question that ultimately we need to do early intervention as soon as we know or even suspect that there's going to be an issue, to train caregivers to provide this in the home. It doesn't have to be 24 hours. We know that even in children from 18 months to 4 years, that 2 hours a day or even 1 hour a day of gentle restraint with a hand or putting a sock on the contralateral hand, or I think even Janet Eyre has been doing some stimulating work, putting objects on one side and trying to get them to reach with that. And I think early intervention is exactly
I was looking at children at risk. I mean, I was doing studies, and the typical, what you mentioned is typical, out of 4 children, you have the one hypertonic and stiff, you have the one hypertonic and lax ligament, and you have maybe 2 that are typical. And each one of those children, when I followed them until they were older, most of the neurological problems, ADHD, autism, DCD, they all develop from the two extremes. So it means that you have even to touch both hands is extremely important, or to prevent the plagiocephaly, the torticollis. Those problems are ignoring the one side of the brain. And then they have problem, and there is nothing you can do because you cannot go back to the first 3 months.
Okay, thank you. We're going to break, אנחנו נפסיק פה, נצטרך הפסקה של 25 דקות, בשעה 1:05 אנחנו מתחילים את הפאנל. בבקשה.
גבירותיי ורבותיי, בשעה 1 בדיוק, פאנלים אורלי וילנאי עושים סדר חדש.